Hi, this is Dr. Kathy Vierhus, and I'm doing the lecture for this week. It's easier for me to do it this way than to try to record class. So I'll go over all the information that you need for week 4. I can't believe it's week 4 of the semester already. So let's go ahead and get started. I'm going to share my screen, and we'll go ahead and get started on this. Okay, so I won't be facing the camera, but I don't think that'll bother you too much as you're looking at this. But so the first thing I wanted to have on here was the fact that if you do come to class, let's say you're watching this, it's because you've been ill and you are going to be coming to class. The reason that I have this slide up here is that starting this week, in order to have access to class, all face-to-face classes until we know differently, you will need to show your MedCat green dot on your phone or your computer. I realize that you are just answering a couple of questions, and it would be just as easy, possibly you think, to be able to just tell me that you have a green dot, but I actually need to see it. That's just the rule that we have in place, and we're following the guidelines that our university is setting in place for us to be safe. So just an update for you. One of the things I wanted to bring up this week was that you may have noticed as early as Monday morning that when you looked at the sun outside, we had some haziness over the sun, and that's because of the wildfires out in California and Washington, some of the western states, and they are indeed creating some air pollution and some haziness here within the Midwest. The challenge for public health nursing, or public health in general, is the fact that things like this crop up all the time where general public needs to be informed. We usually get that from the news, but we may indeed get it from bulletins from the public health department, notifying the public that there is a health risk. And this would be particularly a risk for those with respiratory ailments, chronic respiratory ailments, such as asthma. This might be a day that you are going to recommend that people with respiratory challenges, the elderly as well, may want to stay indoors, and they may want to stay indoors with the air conditioning on. Again, though, this underlies and underlines our challenge with health equity, because you may have individuals who have asthma, who live in the inner city, who already have a lot of air pollution around them and do not have access to air conditioning in their home. And so they may be subject to this regardless. And so you can put out, we can put out bulletins saying, you know, it's a condition orange air condition right now, and that means that those with respiratory ailments, chronic respiratory ailments, the elderly, those with those children who may succumb to respiratory challenges, we would want to keep them indoors with the air conditioning on, but it does not always work out that way for people to be able to enact that. So another aspect of public health nursing that happens all the time. So we're going to be talking about politics and community empowerment. I know this is not everybody's favorite topic. I myself struggle with the political influences on public health initiatives, and we've seen that really, really heavy with the pandemic. But nonetheless, it's important. It's important for us to realize what happens as far as making changes within guidelines that affect the public health of our community, and then how we can help our community empower themselves. And so that's been in the news a lot as far as protests. These are based on racial issues, but there have also been protests in the past that center on other public health issues. So we know that those things happen, and how can we go about supporting those in a peaceful manner? So the mechanism by which scarce resources are allocated, that really has to do with what we're dealing with. And I've said it before, and I will continue to say it because it's a very, very important concept to understand. There are limited resources. There is limited money. There are limited people. We're limited by time. Any resource we're really limited by. And so we make the decision where we're going to place our resources. And how we do that is through the political forum or through legislation. And that's why it is important for us. The decision-making process really has to do with what we are predicting that we need to concentrate our healthcare dollars and time and efforts towards, and what kind of outcomes we want to have with that. So this table here talks about the different nursing roles that population or public health nursing can have in policy development. Now, obviously, all of us are citizens, as far as citizens of the world. Many of us are citizens of this nation, and that goes along with then paying attention to what's going on, being a good citizen of what is happening within the world, and using your voting rights to be able to sway politicians to be able to represent their constituents within their area. So we have public forums. We might have political meetings where the public is invited to be able to have 2 to 3 minutes to state their case. We may join a politically active nursing organization. So there are many ways that as a private citizen, we can impact the policy development within our nation on public health. Activists go kind of a next step up. Again, activism for some people is not what they want to particularly participate in. But I tell you, even if you're an introvert such as myself, you can become an activist, because some of the things you can do is write your congressman about things that you're not happy with. If you're not happy with the air pollution, it's talking about what we were talking about earlier. If you're not happy about the air pollution within an area, then you can certainly participate in writing letters that support EPA efforts, Environmental Protection Agency efforts, or other initiatives that are going to help with that. You could run for political office, and I'll tell you that some nurses do hold political office, particularly in areas where the coroner or the medical examiner is an elected office. There are many forensic nurses that actually do that. And then you could participate in research that would support the issue that you're concerned about, that you're passionate about. Then you can do that as well. Strategies for promoting policy adoption include, and the first one should be for all of us as a nurse, you should be a lifelong learner and you should stay informed in what is going on. But I'll put this in the context of when I worked as a manager of the forensic nursing team in Madison. So communicating with policymakers, I had days that were designated to do to connect with the area policymakers. They may indeed have been the local politicians for the area, as well as networking. I networked with a lot of people, both public and private, within the community on the sexual health and domestic violence needs in the area. Coalition building. We had several coalitions that I belonged to. I can think of, I think, 5 off the top of my head. We had a neighborhood coalition for ending domestic violence. We had a neighborhood coalition for decreasing victims of violent crimes. We had a neighborhood coalition for decreasing child abuse and neglect. One for supporting immigration rights for people that were here, healthcare rights, and another one that was on just decreasing violent crime in general. Then I was also on what's called a SART team, Sexual Assault Awareness Team, that was actually held at the district attorney's office, and included the district attorney himself and several of his assistant district attorneys. It included the police chief or a designation of his from Madison, plus a representative from all of the police departments around Madison. I think there were 17 of them. And then myself from Meriter, we had a representative from American Family Children's Hospital, Child Protective Unit, and then just various neighborhood coalitions. So we would meet as a SART team. We would talk about the sexual response, how we responded to sexual assaults within our community, what we could do better, what was trending. Schools were involved, because a lot of times the sexual assaults happen within the context of schools, not just the colleges, but the high schools. And so you can read the other ones on there that talk about how you can, the strategies for promoting policy adoption. But that was it for me, because I was interested in helping with policy adoptions that supported victims of violent crimes. Now, community empowerment has to do with having the community members themselves being empowered to be able to move forward. And it's the opposite of powerlessness. So that's what a lot of people feel frustrated over. I think that's when we get into some of the more demonstrative protesting, is when people feel powerless. And what our goal really is with community empowerment is, as healthcare professionals, we want to help them really have a voice and to be able to get started with their empowerment efforts and being able to influence the decisions that are made for their community. And our goal really at the end is to step away and to be able to have those to be self-fulfilling, self-motivating, self-regulating, and self-perpetuating communities. But that doesn't always happen. I can say most of the time it does not. It is hard to step away from those. Sometimes the neighborhood community groups feel abandoned when healthcare workers say, you know, we need to move on to another one of our priorities. And again, we talk about resources, right? I would have regular conversations with my senior leadership at Meritor on how many of these groups I should be involved in, because really from their aspect, they wanted me in front of patient care and in improving patient outcomes, which we did do. But there's also this networking that you need to do out in the neighborhood and to help empower the community themselves. So really what we're doing is we're fostering the perception as we're community partners with the community. We're not telling the community what they need. We're helping to partner with them so we can arrive at solutions that work for both from a healthcare perspective and from a community perspective. And I think that is really important. Shifting ownership back to the people is what's important, and the community itself should take pride in the ability to have influence over some of these healthcare policies. Now, in your reading this week, I did have quite a bit reading, or your viewing on websites, on videos. I did have quite a bit on telehealth, and the reason that I did that was because it is a perfect illustration of policy development that happened very rapidly because everybody had the same goals in mind. When COVID-19 hit and we suddenly didn't want people going to their healthcare providers if they didn't need to, virtual visits came to the forefront. I've shared with you that I'm doing that with Penn State University for sexual assault, to help sexual assault nurses in the rural communities who may not see more than 1 or 2 sexual assaults in an entire year, to partner with them to bring expertise and help them to do the best job that they can do for the patient. But that's just one example. I'm sure that all of you have had seen the commercials or even gotten information from your own insurance company on how you can do a televisit. And it was something that was really had been in the works for many, many years. But there was a lot of red tape that it was going through. There was a lot of technical issues that people didn't want to spend the money to work out. And then suddenly the pandemic happened, and there was actually an executive order that needed to have Medicare and Medicaid fund these. Before, Medicare wouldn't even fund a virtual doctor's visit, primary care visit, and now it is the thing to do. So it just goes to show you that we can move things quickly when there is a strong need for it, and we are in agreement across the political board that this is something that we need. So that's the reason I included a lot in telehealth. It's just really interesting to be living through this to see when something is really needed, how quickly policies can be changed. Now, we're also going to just touch on economic influences on population health. And this grid is here to show you really where the US dollars are spent. This is from 2018. That's actually probably a pretty current statistic for most of the statistics that we get. And it shows that really 32.7 of it is hospital care. And many of you are looking at working within the hospital in the acute care setting. And that's where that money is spent. We know, I'm sure you have heard that in the last 5 or 6 years of someone's life, they spend about 75% of their healthcare dollars. I mean, that's just because of technology. It's because we do a lot for people that are gravely ill, and rightly so, but it is very expensive. And so sometimes decisions need to be made on whether or not we're actually doing people justice by putting them in the hospital and extending their life a few months for a very expensive bill. It's easy to make decisions based on statistics and things like that when it's not personal. But you know, if you're talking about your own mother, your own father, your own grandmother, your own grandfather, it really changes your perspective on whether or not you want us to spend that healthcare dollars on the last efforts that we can do to try to save them or give them some quality of life. You'll see physician services are up there. I know when you did your global healthcare assignments, you looked at kind of some of the reimbursement systems around the world, and you realized that our physicians here in the United States are paid very well compared to some areas where they are paid basically the same as everybody else. So just kind of a look at the way we do this. I look at this, there's 2 slides in this PowerPoint slide deck that I look at and say, ding, 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 please know this for the quiz. So you have a quiz, I will go over that. You have a quiz at the end of the week. It opens on Friday. And this is one of the things that will be on there, I'll tell you right up front, because these are really important concepts to have. The 3 fundamental economic principles are: 1, resources are always more limited than what is needed. Always, people. Resources are limited than what we want to spend them on. You can think of that as your own budget, right? Very, very few of us, maybe billionaires, actually have enough money to fund everything they want. And you know, the needs, our wants versus needs kind of increase as we get wealthier. But when it comes to resources for healthcare, it is a bottomless bucket. And so there is never enough resources. So we have to make decisions. Resources have alternative uses. You could have Pam, the nurse, work in ICU, or you could allocate that FTE, that full-time equivalent, to Pam working in OR. Or you could say Pam should work out in the community. Hospitals are making these decisions all the time about where their resources should go, their people resources. How many people do we have staff the Med-Surg unit on 6 East, and how many nurses do we have staff the post-anesthesia recovery unit? Very hard decisions to make sometimes, particularly when we know that we're always short-staffed. And then the last one, different people have differing ideas on how resources should be used. This is where all the conflict comes from. People have their viewpoint, their world viewpoint, their viewpoint at the workplace, and are very passionate about that. And that's not a bad thing. People should be passionate about what they want, but there are not unlimited resources, and so sometimes compromise has to be made. Sometimes people just have to give in. Sometimes directives just have to be made and people are told what to do. So important for us to know that resources are more limited than what we want. Resources always have another use, whether it's money or people or facilities, and different people have different ideas. Okay. So the next one's talking about factors that contribute to increased healthcare costs, and this is probably something that you already know. I myself am a baby boomer. I'm an aging population. I'm right at the end of that group, but we know that the growing population of baby boomers who are over 65 now, who are on Medicare, who are utilizing those dollars, who have been used to having healthcare needs met in the United States. It's just a growing population. It's going to put more and more of a burden on the healthcare economy in this country. Greater emphasis on technology, that you know that is usually means more expensive. You have a better MRI, you have a better robotic ability to do knees within the OR. Those things cost money. Emphasis on costly specialty care. We know that we are getting more and more specialized with our medical care, and that is indeed more costly. And then we have our uninsured cost shifting. So if somebody comes into the emergency room, they are not insured, and they don't have the means to be able to pay for any of their care, or a minimal amount of their care, then that cost has to be shifted somewhere. You know, you hear about, the hospital will write it off. Well, when the hospital writes something off, all it means is they take it from one column and put it in another. They still have to pay their nursing staff. They still have to pay their physicians. They still have to pay for the facilities. They still have to pay for supplies. And so that is important. Last week, you may have heard that the president signed an executive order for drug prices. Drugs are typically much more expensive in the United States than they are around the world, and that has to do with the ability for other citizens to pay for their drugs. But typically what happens is ours are highly inflated, and you'll hear about people traveling down to Mexico or going up to Canada and getting some drugs, maybe some drugs that they can't get here, but other than that, they also go because they can get cheaper drugs when they go into these other countries. So an executive order was written in order to start looking at that and to indeed say, you know, the United States citizens should not be paying more for their drugs just because they live in this country. This is another one that is going to be on the quiz, so I want you to pay attention to this, the 5 A's of healthcare access. And this really has to do with how can people get healthcare and how can they, is it the healthcare that they need and want? So availability, obviously I've talked before about, you know, if your clinic's only open from 8 to 4 o'clock Monday through Friday, you've got a great majority of your population that cannot come during that time. They may not be able to take off time from work. If they take off time from work, they don't have any time to be able to do that where they would get paid, and so they're taking money out of their pockets if they actually come in for a healthcare appointment. Plus, they may have to pay for the healthcare appointment, even if it's just a copay or an additional percentage of them paying for their bill. Accessibility, again, can they actually get there? Is it only available? Do they only use public transportation? They don't have a car, and can you get to this clinic by public transportation? Or would they have to pay for a taxi? Or would they have to wait and find a friend who can take them, and then they're just not going to come? Accessibility has to do with telehealth too. That's one of the main reasons that telehealth is really impacting the ability to the way we deliver care, because now we can access, let's say, the elderly in their home to be able to talk to us and visit with us, and us to be able to care for them. Accommodation means, you know, if they show up and they are in a wheelchair, they're using a walker, they don't speak English, you know, can they get the same type of care if those challenges or obstacles are in their way? Is the form of care acceptable to them? Are they willing, the patient, is that acceptable? So if you're offering only, let's say, male family practitioners in a particular clinic in order to serve females who are pregnant and for prenatal care, would certain cultural entities not feel comfortable with going with a female who's pregnant to go to a male doctor, or a male primary care nurse practitioner, physician's assistant, or something like that? And is it affordable? Can they afford it? Is it affordable because they have insurance? Is it affordable because it's a free clinic? Or is it not affordable because they can't possibly pay for the care, and thus they wait until it gets to the point that they can't wait for care anymore, and then they end up in the ER, which we all know is the most expensive care that you can receive. So you learned last week, as you were talking with each other, that we compare unfavorably to most developed nations as far as our healthcare system, and we're the only developed nation not to have a form of universal healthcare coverage. We did have something introduced several years ago, the Affordability Act, and called the Obamacare by some, and that was an open market. It started with really letting people know that they needed to get health care. It was going to be at a reduced cost, but they still needed to pay for a premium. If they did not pay for a premium, they would be fined. And many people would look at this and say, this is not universal health care coverage, because we are not covering everybody. We are still basing that on their ability to pay that premium. And whether or not a table that somebody has developed says somebody can afford health care coverage, that premium, let's say it's $50 a month, whether or not that table says based on their income that they can pay that is different than reality on whether or not somebody actually can. So we do not have universal health care coverage in this country yet. So some of the deficits that we have seen with respect to our quality of care here. We have the challenge that we don't have the longest lifespans, which is a large indicator of the quality of care within a particular area. We are not highly efficient. We have huge issues with equity, and we are just not really trending up with the leaders within the world as far as our healthcare system. So that's just kind of it in a nutshell. I do want to remind you of the quiz that opens up this Friday. It opens up at 2 o'clock, which traditionally would be right after our Friday class ended. At 2 o'clock, and it actually is open until the following Wednesday at 8 o'clock. I don't know where those time and dates came from, but they have historically served the students well, so we have kept them. So Friday until Wednesday, you can take the test. It does not have a time limit. It is open book. I will caution you on feeling that you don't have to prepare for this quiz because it's open book and you don't have a time limit, because if you've ever done that before, you can find that it's extremely cumbersome. So I would recommend that you do watch all the videos that we have listed in Blackboard, that you do look at the PowerPoints, and that you know where those resources are, so that if you have a question on the quiz, that you can look it up. It is on the first 4 weeks, so it does cover things from this week. It's 25 multiple choice questions. I have not gone to scenarios yet. We may do that later in the semester, but for now it's 25 multiple choice questions, and it's in Blackboard. If you have any questions on that, let me know. You have 2 attempts to take it. It will record the highest attempt for you. Okay, and your quizzes are worth 5% of your total grade. So 15% for the 3 quizzes, but this one is worth 5%. Now you have a class assignment for this week. I'm going to stop sharing my screen so I can talk to you. You have a class assignment for this week. It is an unfolding case study on a chronic elderly gentleman who came home from the hospital, and you are asked to walk through for initial home health visit with Darren, the public health nurse who is coming to see him. And there is a drop box for that. So whether or not you attended in person this week or whether you are attending virtually, you still have the same assignment, and that is to put that in the drop box by Sunday. So the 2 assignments for this week: the quiz that opens on Friday and is closed the following Wednesday at 8 o'clock, and the unfolding case study that is due by Sunday. If you have questions, as always, on anything, please reach out to me. Have a good week.